Physiology and anatomy of the endocrine system, starting with anti-diuretic hormone, or ADH. The solute concentration of the blood, or blood osmolarity, may change in response to the consumption of certain foods and fluids, as well as in response to disease, injury, medications, or other factors. Blood osmolarity is constantly monitored by osmoreceptors, specialized cells within the hypothalamus that are particularly sensitive to the concentration of sodium ions and other solutes. In response to high blood osmolarity, which can occur during dehydration or following a very salty meal, the osmoreceptors signal the posterior pituitary to release antidiuretic hormone, or ADH. The target cells of ADH are located in the tubular cells of the kidneys. Its effects is to increase epithelial permeability to water, allowing increased water reabsorption. The more water reabsorbed from filtrate, the greater the amount of water that is returned to the blood and the less that is excreted in the urine. A greater concentration of water results in a reduced concentration of solutes. ADH, also known as vasopressin, because in very high concentrations, it causes constriction of blood vessels, which increases blood pressure by increasing peripheral resistance. The release of ADH is controlled by a negative feedback loop. As blood osmolarity decreases, the hypothalamic osmoreceptors sense the change and prompt a corresponding decrease in the secretion of ADH. As a result, less water is reabsorbed from the urine filtrate. Interestingly, drugs can affect the secretion of ADH. For example, alcohol consumption inhibits the release of ADH, resulting in increased urine production that can eventually lead to dehydration and a hangover. A disease called diabetes insipidus is characterized by chronic underproduction of ADH that causes chronic dehydration. Because little ADH is produced and secreted, not enough water is reabsorbed by the kidneys. Although patients feel thirsty and increase their fluid consumption, this doesn't effectively decrease the solute concentration in their blood because ADH levels are not high enough to trigger water reabsorption in the kidneys. Electrolyte imbalances can occur in severe cases of diabetes insipidus. Thyroid stimulating hormone, or TSH. The activity of the thyroid gland is regulated by thyroid stimulating hormone, also called thyrotropin. TSH is released from the anterior pituitary in response to thyrotropin releasing hormone, or TRH, from the hypothalamus. As discussed shortly, it triggers the secretion of thyroid hormones by the thyroid gland. In a classic negative feedback loop, elevated levels of thyroid hormones in the bloodstream then trigger a drop in production of thyroid releasing hormone and subsequently TSH, or thyroid stimulating hormone. Adrenocorticotropic hormone, or ACTH. Adrenocorticotropic hormone, ACTH, also called corticotropin, stimulates the adrenal cortex, the more superficial bark of the adrenal glands, to secrete corticosteroid hormones such as cortisol. ACTH comes from a precursor molecule known as POMC, or pro-opiomelanotropin, which produces several biologically active molecules when cleaved, including ACTH, melanocyte-stimulating hormone, and the brain opioid peptides known as endorphins. The release of ACTH is regulated by the corticotropin-releasing hormone, CRH, from the hypothalamus in response to normal physiologic rhythms. A variety of stressors can also influence its release, and the role of ACTH in the stress response is discussed later in this chapter. Follicle-stimulating hormone and luteinizing hormone. The endocrine glands secrete a variety of hormones that control the development and regulation of the reproductive system. These glands include the anterior pituitary, the adrenal cortex, and the gonads, the testes in males and the ovaries in females. Much of the development of the reproductive system occurs during puberty and is marked by the development of sex-specific characteristics in both male and female adolescents. Puberty is initiated by gonadotropin-releasing hormone, or GnRH, a hormone produced and secreted by the hypothalamus. GnRH stimulates the anterior pituitary to secrete gonadotropins, hormones that regulate the function of the gonads. The levels of GnRH are regulated through a negative feedback loop. High levels of reproductive hormones inhibit the release of GnRH. Throughout life, gonadotropins regulate reproductive function and, in the case of women, the onset and cessation of reproductive capacity. The gonadotropins include 2 glycoprotein hormones. Follicle-stimulating hormone, FSH, stimulates the production and maturation of sex cells, or gametes, including ova in women and sperm in men. FSH also promotes follicular growth. These follicles then release estrogens in the female ovaries. Luteinizing hormone, or LH, triggers ovulation in women as well as the production of estrogens and progesterone by the ovaries. LH stimulates production of testosterone by the male testes. Prolactin. As its name implies, prolactin, or PRL, promotes lactation or milk production in women. During pregnancy, it contributes to development in the mammary glands, and after birth, it stimulates the mammary glands to produce milk. However, the effects of prolactin depend heavily upon the permissive effects of estrogen, progesterone, and other hormones. And as noted earlier, the letdown of milk occurs in response to stimulation from oxytocin. In a non-pregnant woman, prolactin secretion is inhibited by prolactin-inhibiting hormone, or PIH, which is actually the neurotransmitter dopamine and is released from neurons in the hypothalamus. Only during pregnancy do prolactin levels rise in response to prolactin-releasing hormone from the hypothalamus. Melanocyte stimulating hormone from the intermediate pituitary. The cells in the zone between the pituitary lobes secrete a hormone known as melanocyte stimulating hormone, or MSH, that is formed by cleavage of the pro-opiomelanocortin, POMC, precursor protein. Local production of MSH in the skin is responsible for melanin production in response to UV light exposure. The role of MSH made by the pituitary is more complicated. For instance, people with lighter skin generally have the same amount of MSH as people with darker skin. Nevertheless, this hormone is capable of darkening the skin by producing melanin production in the skin's melanocytes. Women also show increased MSH production during pregnancy. In combination with estrogens, it can lead to darker skin pigmentation, especially the skin of the areolas